Okay.
Glad he gets to come.
All right, we're going to start out with crutches, canes, and walkers. On page 17. Any questions? Probably just went home and slept.
Yeah, we did.
Not much came to mind. Okay. Crutches, canes, and walkers. One of the major areas of human functioning is locomotion. And so they do test it. So certain things show up on boards with greater frequency than what you might expect them to. And locomotion is one of those. And so to test that, they test casts, traction, canes, crutches, walkers, things that were really probably not emphasized in your school much, were they? That wasn't a major emphasis, I doubt. But on boards, people will always say, like, well, I was surprised at how many things I had about traction or about casts or about things like that. And that's because one of the 8 areas of human functioning they test is locomotion. So you do have to know some of these things. Plus, they're also really good areas for patient teaching because a lot of boards is teaching. What do you teach? What's your goal? What's the teaching? And then it's also risk reduction, as far as reducing risk to skin, risk for immobility problems and that. So let's talk about crutches. The first thing is how do you measure crutches? The reason why they want you to know how to measure crutches correctly is for risk reduction so that you don't cause nerve damage. The first thing is the length of the crutch. How do you measure the length of the crutch? It's 2 to 3 finger widths below the anterior axillary fold to a point lateral to and slightly in front of the foot. Now, what they'll do is they'll say something like, you see an RN or an LPN or an aide measuring a person for crutches. You notice they're doing all of the following. What would you correct? And you have to pick something where they're doing it wrong. Or they'll say which one shows the right, and you have to pick out the correct. The deal is they'll often write sets of instructions where you're measuring from the wrong point to the wrong point. For example, they'll say, to get the length of a crutch, you measure from the axilla. You don't measure from the axilla. You measure 2 to 3 finger widths below the anterior axillary fold. So they'll give you the wrong upper point. Or they'll say you measure to the heel. You don't measure to the heel. You measure to the little toe. You don't measure to the little toe. In other words, you don't measure to any landmark on the foot. You measure to a point lateral to and slightly in front of the foot. So if any of the answers say axilla or any landmark on your foot, they are incorrect. They are wrong. Rule them out. So any instructions with a landmark on the foot or say axilla, they're wrong instructions for how long the crutches need to be. Letter B, the next thing you have to measure is the hand grip. The hand grip can be adjusted up and down, and what you need to know there is when the hand grips are properly placed, the angle of elbow flexion will be about 30 degrees. So those are the 2 things that they're all about with crutch measuring, the length and the angle of elbow flexion when you put the hand grip properly placed. Those are the only 2 things you need to know about measuring crutches. The next part of it is how to teach crutch gaits, because you're supposed to be able to educate people on how to walk with crutches. There are 4 crutch gaits, 2-point, 3-point, 4-point, and swing through. Now, how do you teach each of them? 2-point gait is rather simple. These names are really obvious. You shouldn't forget these names because these names tell you exactly what you're doing, with one exception maybe. In 2-point gait, pretend my arms are crutches, all right? In 2-point gait, you move a crutch and the opposite foot together, followed by the other crutch and the other foot together. And so you kind of walk like this. 2 things, 2 things, 2 things, 2 things, 2 things. So it goes 2, 2, 2, 2, 2. Well, if you were going 2, 2, 2, 2, 2, what would you name the gait? 2-point. Doesn't it make sense?
Yeah.
Because in 2-point, you're moving two things together. What two things? A crutch and the opposite. It's always crutch and opposite. So that's real simple to teach. In 3-point gait, you're moving two crutches and the bad leg together. Two crutches and the bad leg. So how many things is that? 3. So it goes, if this is my bad leg, it goes 3, 1, 3, 1, 3, 1. So what would you call a crutch gait that goes 3, 1, 3, 1, 3, 1? 3-point, seems logical. So what are you moving together in 2-point? How many are you moving together in 2-point?
2.
How many are you moving together in 3-point?
3.
So how many do you move together in 4-point?
4.
No. Because that would be, what would that look like? That would look like this. Right?
Yeah.
And if you could do that, you don't need crutches. So obviously that falls apart. So you move two things together in 2-point, you move three things together in 3-point, but in 4-point, you move everything separately. Because how many things do you have? Well, you have 2 legs and 2 crutches. 2 plus 2 equals 4. So how does 4-point go? Well, 4-point goes like this. You move a crutch, any crutch, just pick a crutch. But once you move that crutch, now you're locked in. Your sequence is now locked in. Because now what must you move? The opposite foot followed by the other crutch followed by the other foot. So 1, 2, 3, 4. 1, 2, 3, 4. That's 4-point gait. It's very slow, but very stable.
What kind of imagery is that used for?
We'll be talking about that on the next page because that's exactly the next thing we need to tell you. Because you do have to know that. Okay, swing through, on the other hand, is for non-weight bearing. For example, amputations where you can't bear weight on a stump. Or whenever they say non-weight bearing. And what swing through is you've seen it. I can't illustrate it because I don't really have crutches. But it's where you can't bear weight on this leg. And so you plant the crutches, all right? And then you swing through, you see? And then and you never put this leg down. And you've seen them. They kind of go whoosh, whoosh, and they just
father-in-law's missing a leg.
And that's exactly what they do. And they just swing it. And it actually can be really fast. Have you seen people go pretty fast with this? They just move, and that leg never touches down. Okay? So when do you use swing through? Non-weight bearing. I did have a student who called me after she took her test, and she says, that crutch stuff was on there, but what you taught me didn't help. Oh, okay. Rather accusatory, but hey, whatever. And I said, well, why didn't it help? And she said, well, you were telling us about the different crutch gaits, and she said, the one they gave me, nothing you taught us helped. And I said, well, what did they tell you? She said, well, he had an amputation, so I didn't know which crutch gait to use. And I said, well, what do you mean you didn't know? She says, well, 2-point wouldn't work, 3-point would. She says, and then swing throughs for non-weight bearing. And I said, well, amputation, you can't bear. Do you see what I'm saying? Why do people make those kinds of mistakes on tests? They're not thinking. Why are they not thinking? They're anxious. And they're not taking steps to manage that anxiety. Now, I will never tell a student, when you take this test, don't be anxious. That's stupid. You can't tell a person not to be anxious because they're going to be anxious as whatever they're going to be. But what you have to teach them is how to what? Manage the anxiety. And she wasn't managing the anxiety. And I was thinking, but if you think about it, could you really do 3-point? 1, 2, 3. You can't do that with an amputation. You have to do swing through. Now, what if they said they had an amputation with a prosthetic device? Could you bear weight? Yeah. Okay. Letter D on the next page, which is what you asked, which is when do they use these? In what situations do they use these? You also have to know that. Now, this is easy Because there's a little saying we often use, and that's even for even, odd for odd. Even for even, odd for odd. Now, how does that work? Well, let's plug it in. Letter D, number 1. Use the even numbered gates, which are what? 2 and 4, correct? When the weakness is evenly distributed. That's even for even. Meaning use an even numbered gate when you have an even number of legs messed up. Use 2-point for a mild problem and 4-point for a severe problem. So generally, answering your question, when do you use 4-point? With severe bilateral weaknesses. When do you use a 2-point gate? Mild bilateral weaknesses. Because if you see, what my point is this, is if they give you a question about what crutch gait will you teach, all you have to do to get it right is ask yourself how many legs are affected. If it's an even number of legs, which would be what? 2, then pick 2 or 4. Even for even. Okay, D, number 2 here. Use the odd numbered gate, and there's only one odd numbered gate, and that is 3. When one leg is odd. That's the odd for odd. So if you say, how many legs are affected? 1. Well, what kind of a number is 1? Even or odd? Odd. So pick the odd numbered gate, which is 3. But if you have 2 legs affected, is that an even or an odd number? Even. So pick an even numbered gate, 2 or 4. 2 for a mild, 4 for a severe. And if they can't bear weight, you go swing through. And if they're an amputation, you go swing through. So I'm going to give you some examples, and I want you to tell me which crutch gait you would teach, all righty? And I just want you to write it down. Number 1. Early stages of rheumatoid arthritis. Early stages of rheumatoid arthritis. Left above the knee amputation. First day post-op, right knee replacement, partial weight bearing allowed. Right or left? Left. Did I say left or right? Right total knee replacement, first day post-op, partial weight bearing allowed. Advanced stages of amyotrophic lateral sclerosis, ALS. Advanced ALS. Left hip replacement, second day post-op, non-weight bearing. And just write down the crutch gait you're going to teach. Next one, bilateral total knee replacement. Bilateral total knee replacement. First day post-op, weight bearing allowed. Bilateral total knee replacement. First day post-op, weight bearing allowed. And last patient, bilateral total knee replacement, 3 weeks post-op. Okay? So do you have your crutch gaits down? Okay, what's it read? What's the first one? 2. Why 2? Did I tell you how many legs were affected? No, but it was a systemic disease. And what should you assume if it's a systemic disease? Both legs. So is 2 an even or odd number? Even. So you would have picked 2 or 4. Why did you pick 2? Early. Okay, then what was the next one? Swing through. Then what? 3. Then, which one? Everybody's sitting there like, are you just not answering, or is everybody getting 4? Okay. Then swing through. Then 4. Then 2. Did you get those? Any questions about any of them? Okay, good. Just remember, even for even, odd for odd. All right, stairs, going up and down stairs with crutches, letter E, going up and down stairs. Again, it's going to be patient teaching. Remember the saying, up with the good, down with the bad. Up with the good, down with the bad. In other words, when you go upstairs with crutches, go up with your good. That means lead with your good. So what goes first? Crutches or the foot? Foot. So crutches go what? Second. Up with the good. Up with the good. See that? However, down with the bad. Down with the bad. See that? Down with the bad. But it actually makes sense. Because could you go up with the bad? Okay, I'm going to put the crutches up first. Okay, now the crutches are up. Okay, now how do I... See, you can't get up because the crutches are there. And when you come down, would you really lead with your good leg? You know, that would throw, you'd be down a bit faster than you thought. It would just throw you down. So it's always up with the, down with the, and the crutches always move with the bad leg. Canes. Hold the cane on the strong side. People hold canes incorrectly, notoriously. If I have a weak right leg, in which hand do I hold the crutch? The left. But I advance it with the bad leg. So when you walk with crutches appropriately, you're walking like this. If this is your bad leg, you're going like this. And see, when you put your crutch down, you have a nice wide base of support, which keeps you upright. When people do it wrong, they hold the cane on the bad side. And what they do is, here's the bad leg, here's the cane, and they go like this. When they go like that, it's a point. So they have to shift their weight over that base of support. And then they rock back. And they go like this. And if you see anybody doing that, what do you know? They have the cane where? Wrong hand. They need to switch it over and walk correctly. So whenever you see people walking that way, they're wrong. Okay? Even if they are a television doctor. Okay. I will correct people in the mall. I've been known to do that. That's why my daughters will never walk with me when we go anywhere. I embarrass them. But I'll go up to somebody and say, interesting, how have you been taught to use that cane? Because I see that you're actually using it incorrectly. Sometimes they listen, sometimes they don't. But nurses, once you're a nurse, it corrupts you, doesn't it? You're different now that you're a nurse. One of the things that my daughters also, they won't walk with me in a hotel hallway. Because what do I do when I go down a hotel hallway? Because you do it too. You go like this. You're walking down a hotel hallway and this is you. What are you doing? You're looking in rooms, aren't you? Because as a nurse, you cannot go down a hallway without looking through rooms, correct? So I'm looking in all these open doors like this, and my daughters are going, Dad, stop looking in the room. Well, my response is, if they didn't want me looking in the room, they should have closed the door. You know, but I mean, you can't, can you do it? Can you walk by an open door without looking in? I mean, you may have been able to before you were a nurse, but you can't do it now that you're a nurse. It's unavoidable. Try to walk down a hallway next time in a hotel and say, I will not look in any empty rooms. You'll go nuts. It'll drive you crazy. Okay. Walkers. Pick them up, set them down, walk to them. Pick them up, set them down, walk to them. In other words, it's slow. Yeah, it's slow. No big deal. They pick it up, they set it down, they walk to it. They're supposed to pick it up, set it down, walk to it. Pick it up, set it down. What do? They go like this and then they go. Right? They don't do it right. Okay, and number 2, if they must tie their belongings to the walker, have them tie it to the sides, not the front. Why? Tipping over. What's that? I didn't hear you.
Can you repeat that?
Okay. If they must tie their belongings to the walker, have them tie belongings to the side of the walker, not to the front of the walker. So even though it is done by 99% of everybody you see, Boards does not like stuff tied onto the fronts of walkers. Alrighty? And Boards doesn't even like wheels on walkers or tennis balls on walkers. You see, even though it's done. Any questions about crutches, canes, and walkers? Just a little refresher, because I figured that if you got a question about that and you hadn't had it in a long time, it might throw you, when it's very simple and very easy to master. All right, let's totally switch gears on page 19 and talk about delusions, hallucinations, and illusions. In other words, some psych. Let's talk psych. Do you see where your first point, letter A, says neurosis versus psychosis? I want you to cross off the word neurosis, and I want you to put non-psychotic, so that the statement now says non-psychotic versus psychosis. Because this is probably one of the most important points I could talk to you about in psych. Because this is probably the most common reason why people with whom I work miss psych questions. Because right out of the gate, they turned left instead of turning right. They went the wrong way out of the gate. And the reason why they go the wrong way out of the gate on a psych question is the very first thing you have to do to get a psych question correct is decide, is my patient non-psychotic or psychotic? That's the first thing you must do in a psych question. You must decide, am I dealing with a psychotic or a non-psychotic? Why does that matter? How many think that might be an important point?
Whether you're dealing with reality or not.
Exactly. It's huge. It'll determine treatment. It'll determine goals. It'll determine prognosis. It'll determine medication. It will determine length of stay. It will determine legalities. It will determine everything. So if you don't even know if you're working with a psychotic versus a non-psychotic, how in the world do you expect to get the question correct? And you won't. You may guess right once in a while, but over the long haul, you're going to do horrible. So one of the very first thing you must do, and I want you to start doing it, whenever you take a psych question, what's the first question you'll ask yourself? Is the patient psychotic or non-psychotic? Now let's talk about those differences. Number one, a non-psychotic person. Do you see wherever you see the word neurotic, just replace it with non-psychotic? A non-psychotic person has insight and is reality-based. A non-psychotic person, yes, they're emotionally ill. Yes, they have emotional distress. Yes, they have mental and behavioral disorder. But they are not psychotic. They have insight. Insight means they know what's wrong with them. They know they have a problem. They know what the problem is. They know how it's messing up their life. And they are reality-based, meaning what they're believing, see and hear and smell and feel and taste is what you believe and hear and see and smell and feel and taste. So these people are mentally distressed and emotionally distressed, but they're not psychotic. So how do you treat these people? What kinds of answers do you go and select? Now, if you've been doing psych questions right, you know what I'm talking about. So what do you pick? What kind of answers do you pick in that case? What techniques do you use in that case? You guys never made this differentiation when you take psych tests? What was that?
What was the question?
The question is the first thing you have to do when you get a psych question is decide if your patient is a psychotic or a non-psychotic. And if you find out, if you say, oh, this is a non-psychotic patient, then what approaches, what kinds of answers, what kinds of techniques, what kinds of approaches do you look for as being the right answer for this non-psychotic, mentally disturbed patient? Good therapeutic communication. What do I mean by that? Good therapeutic communication.
Asking them to talk about how they feel.
Why? Because isn't that what you do for everybody?
Yeah.
Do you do that for med-surg patients? Do you use good therapeutic communication skills with med-surg patients?
Yes.
Do you use good therapeutic communication skills with pediatric clients? Do you use it with OB clients? Community health clients? So the point is this. If a person is mentally disturbed, mentally distressed, emotionally disordered, but they are non-psychotic, the right answer is the right answer that would be right for everybody and anybody that just displays really good communication skills. Like, tell me more about what you're experiencing right now. Or that must be very difficult. Or all that has happened has been fairly overwhelming for you. Or how are you feeling right now? Or, those kinds of things. Tell me more about. What do you mean by? Can you explain to me more fully about? See, those are answers. Have you ever had those questions where they give you a med-surg patient and ask you what would you say, and they're just testing reflection, clarification, amplification, restatement? Remember those therapeutic communication skills you learned in basic nursing that you use with everybody? Well, that's what you want to do with a non-psychotic. There's nothing special that you're supposed to do or know differently with a non-psychotic than any med-surg, peds, or OB patient. So if they say to you, Alice is depressed, and she says, I hate this depression, it's ruining my life, I have absolutely no energy to do anything. Now, is she psychotic or non-psychotic? How did you know she was non-psychotic?
She recognized the problem.
She recognized her problem. She had insight. So that makes her, but she is depressed. So what would you say? Well, you wouldn't use any real fancy sick psych strategies. You would just say to her, well, how are you feeling right now? Or what is currently causing distress for you? Or how much energy do you have today? Do you have enough energy? That you just, whatever you would ask anybody else, just good communication skills. So how hard of a question is a psych question for a patient with a psych problem who is non-psychotic? Is it hard or easy? It's easy because you're just going to use good general therapeutic communication. And there's nothing special you were supposed to have known about it. Okay, now, however, let's talk about the next group, the psychotics. Letter B, or number 2. The psychotic person has no insight and is not reality-based. In other words, they don't know they're sick. They think everybody else has the problem, not them. Have you ever met these people? What do they say about themselves? I'm not sick. Who do they blame? Everybody's got, it's the doctor, it's the nurses, it's my neighbors, it's my wife. So you have to understand that psychotics don't think they're sick. And if they say they're sick, because I've heard psychotics say, I'm a schizophrenic, undifferentiated type. And they'll even quote the ICD-10 code for insurance purposes. But yet then they say that the Martians are causing all their problems in life. Well, that's not insight. Because insight means you know you're sick and you know how it's messing up your life. Well, they may be able to state the disease, but that doesn't mean they have insight. Do you hear that? How many have heard psychotics tell you that they've actually told you their diagnosis, but they have no insight? Okay. Now, these people are treated very differently, because what does not work with these people? Good therapeutic communication skills. Because that assumes that people are rational, reality-based, and know they have a problem. Well, these people don't have any of that. So what you've got to memorize is unique, specific strategies, which I will teach you on the next page. But for right now, let's move into symptoms. Delusions, hallucinations, and illusions are psychotic symptoms. Only psychotic people get these. Non-psychotics do not have delusions. Non-psychotics do not have hallucinations. And non-psychotics do not have illusions. So the minute your patient has a delusion, they have crossed the line and they are now in the camp of psychotic. So remember Alice that was depressed that I talked about a couple minutes ago? If they said, Alice is depressed, she says, I can't stand this depression, it's ruining my life, what symptoms would you expect? You got the question? What symptoms would you expect in this lady? Select all that apply. Okay, would you pick decreased energy level?
Yes.
Psychomotor retardation, meaning everything kind of slows down. Delusions of persecution. No, that would be totally out the window. Why? Because she is non-psychotic, and non-psychotics don't have delusions, hallucinations, and illusions. So you could automatically rule that out. Now, if they are psychotic, you rule those in, because they do have those. So let's talk about these psychotic symptoms in depth, because I'm going to teach you what they are and then how to treat them. The first psychotic symptom is a delusion. A delusion is a false, fixed, F-I-X-E-D, fixed, which means they don't change it. A false, fixed idea or belief. There is no sensory component. With a delusion, you're not hearing, feeling, tasting, seeing, smelling anything. It's all up here. You're thinking it. You're not feeling it. You're not sensing it at all. It's just a thought. Now, there are 3 types of delusions. The first is a paranoid delusion, which is a false, fixed belief that people are out to harm you. Like the police are out to kill me, the mafia's out to kill me, my wife is having me committed so she can run off with the psychiatrist, the kids are lying about me so they can get my house, the neighbors are shining lasers on me to hurt me, that kind of stuff. Grandiose delusion is a false fixed belief that you are superior. So this is where you think you're Christ or Muhammad or Genghis Khan or, whomever. Or you generically think that you're the world's smartest person. You're the world's greatest person. The future of the universe hinges on you. Those are all grandiose thoughts. The third type of delusion is a somatic, which is a false fixed belief about bodies, about a body part, about your body. In other words, I have x-ray vision, I can melt stone with my eyes. My brain is a Martian superconducting proton accelerator. There are worms inside my arm, my body is hollow. You're pregnant, you're 83, and you're male. You know, those are delusions, somatic delusions. Now, hallucinations. How are hallucinations different? A hallucination is a false, fixed sensory experience. You see, with a delusion, there was no sensation going on. With hallucination, it's purely sensory. You see, hear, feel, taste, hear, feel, taste, smell, all those things. So how many senses do we have? We have 5. So how many types of hallucinations? 5, 1 for each sense. The most common hallucination is letter A, auditory. And auditory, A-U-D-I-T-O-R-Y, auditory hallucination, where you hear things. And primarily, they are voices telling you to hurt yourself. So the most common hallucination is an auditory hallucination, and the most common auditory hallucination is voices telling you to harm yourself. That is by far and away the most common hallucination reported. The next most common hallucination is a visual, which is seeing things that are not there. The third most common is tactile, T-A-C-T-I-L-E, which is feeling things that are not there. And the last two are gustatory, G-U-S, and then the word tat, T-A-T, and then O-R-Y, gustatory, which is tasting things that are not there. And the last one is olfactory, O-L and then the word factory, which is smelling things that are not real. So you have auditory, visual, tactile, gustatory, olfactory. The first 3 are the most common in that order. The most common is auditory, second most common is visual, third most common is tactile. The last 2, gustatory and olfactory, are relatively rare, and you don't usually hear of them much. Now let's turn the page and talk about an illusion. What is an illusion? Well, an illusion is a misinterpretation of reality. A misinterpretation of reality. You're misinterpreting what's going on. It is a sensory experience. Sensory. Well, that's just great. Because now what two are we going to confuse? Because they're both sensories. Hallucinations are sensory, right? And illusions are sensory. Well, that's bad, because now how are you going to tell them apart? And that's what that next part says. Number 2, differentiation between illusions and hallucinations. In other words, how do you tell the difference between a hallucination and an illusion? Well, here's how you tell the difference. With illusions, there is a referent in reality. With an illusion, there is a referent in reality. Now let's talk about what that means. A referent, R-E-F-E-R-E-N-T, R-E-F-E-R-E-N-T, referent. What a referent is something to which a person refers when they say something. So, with an illusion, there is a referent. There's actually something there. They just misinterpret what it is. With a hallucination, there is absolutely nothing there. So it's probably best understood by illustration. If a client says, "Listen, I hear demon voices." Listen, I hear demon voices. Of what is that an example? That is a hallucination. Why? It was sensory. and there was nothing there. What about this example? A client overhears nurses and doctors laughing and talking at the nurses' station and says, "Listen, I hear demon voices." Now they said the exact same thing. Of what is that an example? Why is that an illusion? It was the same thing. They said the exact same thing. The question bothered to tell you that there was actually real people talking, making real sounds that they misinterpreted. In that case, it's an illusion. What's this? During your interview, a client stares at the wall and says, "Look, I see a bomb." They stare at the wall and say, "Look, I see a bomb." B-O-M-B. Hallucination or illusion? Hallucination. What about this? During your interview, the client looks at the fire extinguisher on the wall and says, "Look, I see a bomb." What's that? That's an illusion. Why? Was there something there? Was there a referent? Was there something in reality to which they referred? Yes, that was the fire extinguisher. So, is it really going to be hard to spot an illusion on the test? Why is it going to be easy? Because they're going to add a whole bunch of words, a whole big sentence telling you there was actually something there. And when you see all that there, you go, "Oh, that's an illusion." Okay? So it's sort of like an illusion is a hallucination with a referent, basically. Now the bigger question is letter E. How do you deal with these psychotic symptoms in a psychotic patient? When dealing with a patient experiencing psychotic symptoms such as delusions, hallucinations, and illusions, the first thing you, the nurse, must ask yourself is, what is their problem? In other words, what kind of psychosis do they have? I hope you guys were taught that there are basically 3 types of psychosis. Were you taught that? Because if you weren't, I don't understand how you're supposed to answer questions. Because these 3 different types are huge differences. The first type of psychosis is what they call a functional psychosis. Now, you don't have to know the names of all of these. You just have to know there are 3 types and what they mean. The first type of psychotic is a functional psychotic. And what do you suppose that means? Functional. They can function in everyday life. Can they have a family?
Yeah.
A marriage?
Yeah.
A relationship?
Yeah.
A job? They can do all that and live alone, take care of themselves, pay their bills, pay their taxes. They can function. But they are what? Psychotic. They can function, but they're psychotic. Now there are 4 diseases that make up 90% of this category. And they are what I call the schizo major manics. The schizo major manics. Now what are those? Schizo for schizophrenia. The second schizo is schizoaffective disorder. I hope you've heard of that. The third one is major depression, not depression. You understand? Depression is not psychotic. Major depression is psychotic. So it has to have major there. And then manic. People that are acutely manic. So are bipolars functional? Yes. But are they always psychotic? No. They're only psychotic in what phase? The manic phase. The rest of their life, in fact, you guys could be bipolars and I wouldn't even know it. You could all be bipolars for all I know. So what are the 4 functional psychoses? Schizo, major, manic. All right. Now, the next psychotic is the psychosis of dementia. Now, what's these people's problem? Why are they psychotic? Why do they not know reality and have no insight? Why do dementia clients not know reality, and why are they not having insight? Why do they lack insight? What's that? Well, why is the memory messed up? Thought I heard it. Brain damage. Actual damage to the brain. The brain is actually damaged. Now, in the functional, is the brain damaged? No. It's just the chemicals are out of balance and they don't really have it. They haven't learned adaptive behaviors well. But in this case, with the dementia, there's actual brain damage. And that's why they're psychotic, the brain damage. These would be people like Alzheimer's. Do you ever notice anybody that after a stroke, they're kind of psychotic after a stroke due to the damage? That would be this. Have you heard of organic brain syndrome? That would fall under this category. Anything that says senile or dementia falls in this category. And lastly, number 3, the third type of psychotic is psychotic delirium. Delirium. D-E-L-I-R-I-U-M. D-E-L-I-R-I-U-M. Delirium. And we'll talk about these people. But here's the deal. What's the first thing you must do to get a psych question correct?
Ask if they're psychotic or non-psychotic.
Psychotic or non-psychotic. If you decide they're non-psychotic, what answers do you pick? The best good therapeutic communication response. That would be true for anybody. If you decide that they are psychotic, then what step must you take?
Functional or not.
Decide which of the 3 categories that person falls in. Are they functional? Are they dementia? Are they delirious? Because you're going to use different approaches for each of these. Because not all psychotics are the same. So let me illustrate how you're going to answer questions differently. Letter F, let's talk about the functional psychotic. Does this person have brain damage? No. So number 1, this patient has the potential to learn reality. Why can they learn reality? Because they don't have any damage. They can learn it. They might need some meds to balance some chemicals, and then you might need to set some structure, but they can learn it. They can improve. Well then if they can learn it, what's your role as a nurse? If they can learn reality, what is your role as a nurse? Teach reality. So how do you teach reality? You use the 4-step process that's here. This 4-step process is the way we teach reality to a functional. First step, acknowledge feeling. Second step, present reality. Third step, set a limit. Fourth step, enforce the limit. Now, that isn't good enough for me just to tell you that. I need to illustrate to you how that would look in a question. Because boards doesn't say, what's the first thing you do? A, acknowledge feeling. They don't say that. They say, what's the first thing you'll say? And they'll give you 4 quotes. And you're supposed to pick out the one that acknowledges the feeling, or the one that presents reality, or the one that sets a limit. So what do answers look like that acknowledge feeling? If you said, I got to look for an answer that acknowledges their feeling, what would it look like? How would you spot it? What would it say?
So you're saying you feel this and this?
Usually the word feel is in the answer, yes. So you'd say, or you could even specify a feeling, couldn't you? If you don't say the word feel, usually there's a specification of a feeling. For example, you'd say, I see you're angry. Or, you seem upset. or that must be distressing, or that's so sad, or all that has happened has been so devastating, or tell me more about how you're feeling right now. See, all of those go to what? Feeling. And that's the first thing you do. How many have noticed that in psych, if you're between a couple of answers and one of them is talking about feeling, if you pick it, you're usually more right than wrong. Have you noticed that? Because what are you doing? Acknowledging their feeling, which is the very first thing you should always do with a functional. Secondly, you present reality. Well, how does presenting reality look like? Well, it has different forms. One of the classic forms of presenting reality says, I know that blank is real to you, but I do not blank. Do you see what I'm saying? I know that you see that demon, but I do not see a demon. Do you see what I'm saying? I understand those voices are real to you, but I do not hear any voices. Do you see what I'm saying? I understand that you think that the mafia is out to kill you, but in reality, no one is going to harm you. Do you see that? That's one format. The other format of presenting reality is just to tell them what is real. I am a nurse, this is a hospital, and this is your breakfast. Do you see what I'm saying? So you can either tell them what actually reality is, or you can just say, I know that's real to you, but I do not. Both of those are acceptable formats for presenting reality. Either one is good, but it's not the first thing you do. It's the second thing you do. Setting a limit. What setting a limit looks like is when you set a limit, the answer will say something like, that topic is off limits in our conversation. Or, when we talk together, we are not going to address that problem. Or we're not going to talk about that. And sometimes it can go all the way and be as extreme as stop talking about. That would be all right. To tell them to stop talking about those aliens. Stop talking about the voices. And you can be that strong. Or you can be strong enough to say, we're not going to talk about those voices. You see, you can be that directive and that strong. And then enforcing a limit usually takes the format of saying something like, I see you're too ill to stay reality-based, so our conversation is over. That's enforcing the limit. Enforcing the limit is ending the conversation. Enforcing the limit is not taking away a privilege. You see, that's punishing. Does everybody understand the difference between enforcing a limit and punishing them? What are you doing when you punish somebody? What actions do you take to punish? What would be bad answers that would be construed as punishing? Because you've told them to stop talking about the voices, right? And they keep talking about the voices. They violate the limit. So how are you going to? What would be a bad way to enforce it?
Negatively reinforced,
Such as?
taking away their privilege.
Yeah, you can know since you can't follow the rules, you lose your telephone privileges. You lose your refrigerator privileges. You're going to be restricted to your room. No, that's not enforcing the limit. That's punishing them. The only enforcement is ending the conversation. That's the enforcement. Why is that appropriate? Why is it good to end a conversation with them when they are not reality-based and won't stay reality-based?
Because you're not going to accomplish.
You're not going to accomplish anything, and by continuing to talk, what are you reinforcing? The non-reality. Okay? So how does it go? Well, let's talk about this. You have a patient who says to you, and he's schizophrenic. Does that matter? Schizophrenic. Why does that matter? It throws him in what category? Functional. And you know to do the 4-step functional process. He says, schizophrenic says to you, I'm going to kill you all. You're all going to be dead by morning. I'm going to slit your throats, and I'm starting with you. Okay? rather paranoid, violent, delusional thinking. What's the first thing you say to him? What's that?
I understand you're upset.
Right. You could say that, I understand you're upset, or you could say, I see you're angry. I wouldn't say, how do you feel right now? Because I think I know. You know, I mean, sometimes they give you enough data in the question to kind of know what they're feeling like. Okay, so I see you are upset. Then what do you do? What did I tell you to do next? Okay, but they're not going to say present reality. What? Give me a quote. In this case, you'd say, I see you are upset.
But there are no bugs on the wall.
But he didn't talk about bugs.
Okay.
That's the only problem. That is presenting reality, but he didn't say that. He said he was going to kill us all. We're all going to be dead by morning. He was going to slit our throats, and he's going to start with me.
Killing us is unacceptable behavior.
Okay, and I think that's a great answer. I think we could go better with talking about it more positively than negatively. Rather than saying you're not going to kill anybody, I would say we're all going to be kept safe. So I would present the reality, and always try to, if you're between two things, sometimes, Derek, it comes down to one is stated positively and one is stated negatively, and you always want to, rather than saying you can't have, you're on a fluid, you're only allowed to have 10 cc's at breakfast time, you say, you can have 10 cc's at breakfast. You know what I mean? They always like you to state it positively. Like with diets, it's better to emphasize what they can have than what they cannot have. With mobility, it's better to tell them what they can do and so in every way, if you're between two answers, one is positive, one is negative, go with the positive. Does that make sense? Okay, in this case, Derek said what?
Killing us is, murder.
Killing is inappropriate and not going to happen in this situation. Versus, I see you are upset, but everybody is going to be kept safe while we're here. This is do you see? It's the same thing, only stated more positively. It's presenting the reality of what's going to happen. No one is going to get killed, right? Okay, then what do you say? We're not going to talk about that kind of stuff. We're just those kinds of ideas, although they are real to you, are off limits in our conversation. So then he keeps talking about it. I'm going to kill you. I'm going to slit your throat. I've got this knife. I'm going to shank you. What do they say? What do you then say? I see you're too ill to have a reality-based conversation, so our conversation is over. And in reality, in real life, when I work psych, I then offer them a tranquilizer. I say, and we have some medication that can help you control those things. Would you like some? And that kind of thing. A lot of times they do. And I always like to say that because I like to say, I see you're too ill. I love to say that because what's it telling them about their experience? That is a symptom of their illness. And they're gaining, I'm hoping to teach them that it's not them, it's their illness and they need to recognize what's ill me and what's healthy me. And so I always love to say, I know that's a symptom of your illness, but I see you're too ill to have a reality-based conversation. So we're done now. But though I always like to say, but we have medication to help you with those symptoms. Now, again, what am I reinforcing? That's a symptom, and that this is a symptom of your illness. And it's controllable, and we have meds for it, so comply with it. Do you know what I mean? Because non-compliance is the number one reason why psych patients are readmitted to facilities, correct? So I always find that, and then I say, and they say, well, what medication? Well, like Xanax, or what? Well, I don't like, okay, well, you have this. Okay, well, I'll have some of that, I guess. And it works like about 1/3 of the time. And you say 1/3 of the time isn't very good. Oh, it's a lot. I mean, that's pretty good for a psych hospital. 1/3 compliance rate. So then they do well. Okay? So that's a good way to go. Do you understand the process? Acknowledge feeling, present reality, set a limit, enforce. However, if they have psychosis of dementia, who are these people? Dementias. Seniles, Alzheimer's, brain injuries, organic brain syndromes, post-strokes. Number 1 says this patient has a brain problem, structural brain problem, and cannot learn reality. They cannot learn reality. Do you think that makes any difference?
Yes.
What about the functional? What's the positive point about functional? They can learn reality. What's the best for a dementia? They can't learn it. Do you think that difference is minor or major?
Major.
That's a major difference. Do you see why you have to differentiate which of the three categories your psychotic falls into? Because it makes a huge difference in how you deal with it. Well, how do you deal with a dementia, a psychotic dementia, a person who has brain damage, and they can't learn reality? Well, number one, you do 2 steps. The first step is you acknowledge their feeling, and the second step is you redirect them. You redirect them. So what am I telling you you don't do? Present reality. Why is presenting reality for a dementia not appropriate? They can't learn it. And you keep trying to teach something that they can't learn. It's ridiculous. It's going to frustrate them, anger them, discourage you. You can't. They can't learn it. It's impossible. So don't try. So what do? You redirect them, and redirect means to channel them from something they cannot do to something that they can do. Why do you not set limits on their bizarre communication? It's just plain mean, isn't it? That's just mean. Now, I do want to caution you guys. Here's where a lot of people go wrong and they get confused, and there shouldn't be any cause for confusion if you understand this. With your dementias, like your Alzheimer's and your seniles, when you work with them on the unit, what do they tend to get all the time? What's a problem they always have? You ever worked with elderly dementias? What's a problem they constantly have every day related to that they forget? Where they are, where their room is, what day it is. Okay? Now, that is not psychosis. At that point, they are not psychotic. They're just forgetting. Now, when they're having delusions, hallucinations, and illusions, what are they at that point? Psychotic. Okay, now here's the thing. I told you what technique is not appropriate for a dementia client when they're experiencing psychotic symptoms. What is not appropriate? Presenting reality. Don't confuse that with reality orientation. What is reality orientation? What does that mean when you see the phrase reality orientation? Tell them person, place, and time. Is that appropriate with dementias? Yes. Reality orientation is always appropriate with dementias. Is presenting reality appropriate with dementias? No. Do you see the problem with our language that confuses people? Presenting reality versus reality orientation. 2 totally different things. Can you do reality orientation with a dementia? Yes, because you're just dealing with loss of memory. Can you do presentation of reality to dementia patients? No. Can you keep that straight? Because a lot of people are going to confuse that, and I don't want you to confuse it. Let me illustrate my point here. You have a patient with Alzheimer's. Did that matter? In the question, did that phrase matter?
Yes.
Why? It threw them in the dementia category. We knew they were psychotic now, and it threw them in the dementia category. So you've got a patient with Alzheimer's. She's in the waiting room, the lobby of the nursing home. She's all dressed up. It's Sunday. You say to her, "Mrs. Smith, you're all dressed up." She says, "Yes, my husband's picking me up. We're going to go to church." Okay? Problem? Husband has been dead for 10 years. So she has a what? She thinks her husband is alive, but he's been dead. So she has a what? True or false? False fixed belief. So she has a what? Delusion. So she is delusional. So at this point she is what? Psychotic. What do you say to her? So what would be the first thing you'd say to her? My husband's coming to pick me up. We're going to church. What does it say to do? Okay. It says to acknowledge feeling. Okay. In this case, what would that look like? What's that? There's no feeling there, though. No, I wouldn't say "are you." I would say that sounds exciting, or that sounds like an exciting thing to do, or that sounds fun, or that sounds interesting, or I mean, that don't always ask. See, a lot of times when these questions, they tell you stuff so that you are supposed to recognize the feeling. So don't always ask, "What are you? Are you?" Just say, "I see you are happy. I see you are sad." What if it fits? Those are much better answers. Do you see what I'm saying? Because if you say, "How are you feeling?" They say, "What do I think I'm feeling?" You know what I mean? But if you say, "I see," you're acknowledging it. Do you understand what's the difference between exploring feeling and acknowledging feeling? What is the difference? Or is there no difference? There's a difference. Okay, what does explore feeling mean?
Asking.
Digging, trying to find out what it is. Acknowledge means you already know. You're just acknowledging with them that you see that that's what they are. And that's what we're talking about here. Got it? Okay, then what would you say? She says she's going to church, husband driving. I see. That sounds like a exciting thing to do. Yeah, and she said, "Why don't we go have some breakfast while we're waiting?" Now, that's redirection, but I don't know if it's the best one, because she would say, "But if I go to breakfast, I'll miss him. He'll miss me." Do you see what I'm saying? And so I think it's good, but I think that you could probably say something like, "Well, why don't we sit down here and talk about what's going to happen at church today?" Do you see what I'm saying? So while we wait, so she sits down, and then you start saying, "Well, what church do you go to? Who's your pastor? Who's your priest? What do you like about the service? Do you have friends there? Does your family go there? What are you doing now?" That's all what? Reinforcement of intact memory. And isn't that good with dementia? And pretty soon you start getting her turned from church to family. You see, and then you say, "Do you have any grandkids?" And then you get talking about the grandkids. And then you say, "Do you have any pictures?" Right? And they say, "Yeah, could I see the pictures?" "Well, I don't have them with me." "Well, where are they?" "In my room." "Could you show me?" "Okay." Now she's leading you back to the room to show the pictures. She's long forgotten about church and husband, and you're not having a fight. Do you see how you do it? You kind of just redirect them into things. So that's the way you go. What would be the wrong answer to say to her? That sounds exciting,
But he died 10 years ago.
but your husband's been dead. That's called presenting reality, and that's appropriate for a schizo major manic, but it stinks for a dementia. Do you see where the best answer for one is the worst answer for the other? That's why you got to know which one you're dealing with, or you're not going to know what to answer. Are you seeing this? Okay, let's talk about the third kind of psychotic, and that's the psychotic delirium. Description of this psychotic delirium. This is a temporary, sudden, dramatic, secondary loss of reality. And it's usually due to some chemical imbalance in the body. So it's temporary, it's sudden, it's dramatic, it's episodic, it's secondary, and it's usually due to some chemical imbalance in the body. Now, how is that different than functional? It's temporary. What else is different about than functional? It's sudden. How is this different than dementia? It's temporary. It's sudden. It's secondary. You see? So it's different. Now, who are these people? These would be people that are crazy for the short term because of something else causing them to be crazy. For example, have you ever seen anybody go crazy or psychotic because they're on a particular drug? They have a drug reaction and it makes them lose touch with reality. Have you ever seen that? Yeah. Tagamet will do it, as obvious as innocuous as Tagamet could do that. Another area is people that are high on uppers. You know, intoxicated on uppers, they'll be this way. Or withdrawing from downers will be this way. So delirium tremens would be this. Cocaine overdose. Methamphetamine overdose. What are some other chemical situations where you've seen people act crazy? It's temporary, it's due to some other imbalance in their body. What's that? Post-op psychosis, it's due to withdrawing from a downer. Because what's an anesthetic agent? A downer. What are the pain meds? Downers. So as you withdraw from the downers, everything goes up and you have this. Particularly in the elderly. If you have an elderly patient who's had anesthesia and a PCA pump, the third post-op day into that fourth post-op day, they can go wacky crazy for about 48 hours. Just plan on it. And then they'll come right out of it. But they will be loony as a tune. Mm-hmm. So don't start zapping them full of tranquilizers or you'll confuse them and they'll end up in a nursing home when they would have come out of it in 48 hours and gone home. Who else? Post-op's classic. What else?
If they're in the ICU really, really long.
Yeah, ICU psychosis can do it with the sensory deprivation can cause it. What else?
UTI in the elderly.
A UTI, an occult hidden urinary tract infection in the elderly. Classic. Any occult infection, but the UTIs in the elderly are the major ones. Have you heard of thyroid storm? That's another one. Have you heard of adrenal crisis? It's another one. So those are your... I even think roid rage, to some extent, could be classified something like that if they're actually seeing, hearing, hallucinating, and if they're that bad, they can be that. Well, what's the good news for these people? It's temporary. So really, what's the focus of managing these people? Removing the underlying cause and keep them safe. So what is the 2 steps? Acknowledge what? Feeling. And then reassure. Reassure. Of what 2 things are you reassuring them? That it's temporary, it will go away, and they will be kept safe. So reassure them of safety and that it will go away. Why don't you present reality? They're not going to get it. Why do you not redirect them? Because it's not going to work. It's just reassure them. Let me give you an example with all 3. Functional, dementia, delirium, and show you how the answer changes. Because one of the things they do on boards is they change the type of psychosis and they look to see if you change your answer when they change the type of psychosis. Or do you always go with present reality, no matter who you're with, which is the wrong way to go. Okay, here we go. You have a patient with schizoaffective disorder who points to 2 people talking at a table across the room. Got the picture? Schizoaffective, they're pointing to 2 people talking at a table across the room. And they say, those people are plotting to kill me. What would you say? Well, what's the most important word in that whole question? schizoaffective. Why is schizoaffective the most important word? Because it throws them in the category of functional psychotic. So what's the first thing you say to that person in that context? Those two people over there, they're plotting to kill me. I see you are frightened or scared, or that must be frightening. Then what would you say? Okay, but they don't say reality. You gotta know what it's going to look like. What is it going to say?
Those people are not plotting to kill you.
Those people are not plotting to kill you. We're all safe. That's called presenting reality. Then what do you say to that person? Furthermore, we're not going to discuss this. And if they keep doing it, what do you say? They keep talking about the two people over there. I see you're too ill to have a conversation, so we're finished. I'll meet with you in a half an hour, and then maybe you can have a reality-based conversation. Those are all appropriate. Do you see the 4 steps? Okay, let me give you another question.
Are you supposed to remove them from that?
No, not necessarily. No, not necessarily. No, that is not the priority at that point in time. The priority is presenting the reality, setting the limit. Now, if they're escalating and they're starting to do, but there was no escalation in that question. What about this? You have a patient with Alzheimer's disease who during your conversation points to two people sitting at a table and says, you see those people, they're plotting to kill me. What's the most important word in that question? Why Alzheimer's? It puts them in what category? Dementia. So now you know you're going to acknowledge feeling and redirect. So how would we then do it? What would be the answers? That's it. You seem scared. That must be frightening. Now what? Redirect.
What are we going to order for lunch?
That's actually changing the subject. And redirection is not changing the subject. Redirection is going with what they're talking about, but getting it achieved in a right way.
Why don't we go somewhere you feel safer?
Exactly. That would be better than, they will have both of those there. What was your answer? A?
Why don't we go somewhere you feel safer?
Yeah, let's go. We don't like why. Okay, let's go somewhere where you can feel safe. Versus, what did you say? Let's go eat?
Lunch.
Let's go eat lunch. Why would A be better than B? It's more. A is more relevant to what they're feeling and what they're talking. B says, B kind of ignores it, but it's better than presenting reality. Do you see what I'm saying? And that's why they would put A with B, because B's a good answer, but A's better. Do you understand that? Okay. What about this question? A client with delirium tremens says to you, you see those two people over there at the table? They're plotting to kill me. What's the most important word in that question? Delirium. Delirium tremens. So that makes them delirious. So what do you say? I see you're scared. And don't say I promise.
Or I can assure you.
Well, just say you are safe. Just say you are safe, and that will go. That feeling will go away when you get better. Do you see that? You are safe. That's a symptom of your illness. It'll go away when you get better. Now, could you say to the first person who had the schizoaffective, would it be okay to say, I see you're frightened, I'll keep you safe, and that will go away when you get better? No, because they didn't learn anything, right? And you can't say it'll go away when you get better to an Alzheimer because it's permanent. So do you see where the good answer for one is a bad answer for the other? How many of you in your psych questions have up to this point basically treated all psychotics the same? Do you understand now there are 3 varieties and the answers are different? Have you ever had this experience in taking psych questions? Because a lot of people do. Like, for example, you'll get a question that says the patient is hallucinating. What are you going to do? And you go, oh, I'm going to present reality. So you pick present reality. You go back to the rationale and it says, no, you should redirect the patient. And you go, oh, that's interesting. So then you take some more psych questions, and about 30 questions later, you get another question about hallucinations, right? And they say, what are you going to do about this hallucination? And you go, oh, I know. It's what? Redirect, because that's what it was the last time. So you pick redirect. You go back to the answers, and they say, no, you should reassure the patient. And you go, what? I wish you'd make up your mind. Last time you said redirect. This time you're saying reassure him. So you take some more psych questions, and about 30 questions later, you get another question about hallucinations. And it says, what are you going to do about this hallucination? And you go, well, it's either redirect or reassure. I don't know which one. They keep changing, and I don't understand this. And then you go back and forth, and finally, after 20 minutes, you finally just pick one, and you say, well, I'm picking reassure because that's what it was the last time. You go back to the rationale. What does it say? No, you should present reality. Whereupon you yell at the computer screen and say, that's what I said the first time, and you said I was wrong. What's going on here? Why do they always keep changing the answer in psych? Have you ever felt that in a psych question? Well, why do they keep changing the answer in psych? Because they're changing the patient. And when they change the patient, you change your answer. That first one that said redirect, what was probably the patient's problem? Redirect, what was probably the problem? Dementia. The second one, which was reassure, was probably a what? Delirium. The third one, which was reality, was probably a functional, and you completely missed the point, and you're trying to figure out what's the pattern, what's the pattern. That's the pattern. Does it make sense to you? Do you think you can see, do you understand how you're going to see the pattern now? Question?
What happens, because I know you said it's functional, like the 4 different types. What happens if you have like a patient with personality disorder or somatic?
Personality disorders are not considered psychoses.
Okay.
They're considered to be access to baseline factors that come along with, just like mental retardation is not considered to be psychosis. So they are not going to classify borderline personalities. What you do with a borderline personality, probably more than anything else, is if I got a question about not a borderline, but any personality disorder, I would probably use good therapeutic communication skills. Now, are they sick? Some of them are real sick little puppies. But they're not classically psychotic. Do you understand what I'm saying? And the only ones where I would really use the presentation of reality is with
Personality-wise?
There are 3 personality. The personality disorders go in clusters. There's clusters. 3 clusters.
Obsessive-compulsive is in the last one. There's
Right.
borderline, narcissistic,
Yeah.
schizophrenia.
ABN. Okay, that's okay. Thank you. I kept thinking ABD, ABN, ABC. It's what ABN. The letters ABN are an abbreviation for what word? ABN. Abnormal. So I tell people the really abnormal personality disorders are the ABNs. Antisocial, borderline, and narcissistic. Those are the real sickies. The histrionics, the obsessive compulsives, the dissociative, the schizoid, they're no big deal.
Okay.
But your ABNs, your antisocials, your borderlines, and your narcissists, they're the real sick personality disorders. They're the ones that have real problems. And that's where I would probably treat them more like a functional. But for most personality disorders, I would just use good communication skills, basically. The reason why I like the functional protocol for the ABNs is I end up setting what? Limits. And with an ABN, an antisocial, a borderline, and a narcissist, you got to set limits. So that's why I like it with them, because I like to set those limits on those people.
The scores ask us about access, like what would
Oh, heaven. Oh, you mean the multi-axial assessment, access 2, 1, 2, 3, 4, 5. That would not be essential knowledge for you to know. That would be a question that would be hard But axis 1 is the primary psych disease. Axis 2 is only really two things: mental retardation and personality disorder. Really, that's about all they'll ever put in axis 2. 3 is medical conditions, not psych conditions like diabetes, whatever. 4 is psychosocial factors like unemployed, recently divorced, newly married, just had a baby, those kinds of things. And 5 is a score. Ranges from 0 to 100. It's a number, like 35, 52, and it's an estimation of how high you're functioning. 100 being perfect psychological functioning like me, and then 0 being completely disorganized person. You know what I mean? So it's 1 is your primary diagnosis, 2 is two things. 1 is your primary diagnosis, 2 is two things: retardation and personality. 3 is medical, 4 is psychosocial, and 5 is a score. But that's all I'd really want you to know.
Okay.
I haven't heard people reporting that those are on there. Okay, hopefully has this changed the way you're going to look at psych questions? So what's the first big task you have with a psych question? Psychotic or non-psychotic? If you know it's non-psychotic, use what?
Good therapy.
If it's psychotic, you have further work. You have to divide it into what? 3. For the 3, the first step, for all 3, the first step is what?
Acknowledge feeling.
Acknowledge feeling. The second step always starts with the letters RE. Reality, redirect, reassure. And now, isn't it true, now when you think back on psych questions, isn't it true that most psych questions, one answer will be reality, B will be redirection, C will be reassurance, and D will be ignoring? And you see the game they've been playing all this time? Okay. All right. Let's talk about 3 more psychotic symptoms and we'll take a break. Loosening of association. Loosening of association is the fancy way of saying your thoughts aren't wrapped too tight. In other words, your thoughts are all over the map. Loosely associated. The first one is flight of ideas. This is when you go from thought to thought to thought to thought. You actually make phrases. You actually say phrases that are coherent. But the phrases are not tightly connected. In other words, each phrase by itself is coherent. But the phrases together are not coherent. Do you understand what I mean by that? It's a lot of ideas. Whereas word salad, they are sicker. They can't even make a phrase that's coherent. They just babble random words. So who's sicker, flight of ideas or word salad? Word salad. Neologism means making up imaginary words. So they'll say, you're a Brinslabik, or you're a Shabazniak, or the Krenulaks are attacking. They're making up all these new words. Robin Williams makes a fortune on humor based on loosening of association. He can do flight of ideas at the drop of a hat. He can, remember Mork and Mindy? That dates me. Probably you guys don't even know what in the world I'm talking about. Unless you watch Nick at Night. But he used to say Nanu, Nanu, and Shazbot. Those were never in the script. He just neologistically did that on the spot, and they said, "Oh, that's cool. Let's add that in." Because he just completely. Did you ever see him do just stream of consciousness? He can just do it like Good Morning Vietnam. All that flight of ideas stuff going on. So that's sort of it. He's also bipolar. That's why he makes like 6 movies in 2 years, then you don't see him for 3. Currently, you're not seeing him, but he will come out in a year and a half with 3 movies to be released that he made in 3 days. Okay, narrowed self-concept. Narrowed self-concept is when a psychotic, and that's key, psychotic, when a psychotic refuses to leave their room or change their clothes. If you've got a psychotic who will not leave the room and not change their clothes, and I would say it is a functional psychotic. The reason why they're doing it is why. Why is the functional psychotic refusing to change their clothes and refusing to leave their room? Why?
Control.
Not so much control, although that could be an issue. Paranoia could be another explanation, but it's not the number one. Think of narrowed self-concept. What would that mean?
Not worth it.
What's that?
Not worth
That would be sense of, that'd be low self-esteem.
it. Yeah.
This is narrowed self-concept. Your self-concept is how you define who you are. And how they define who they are is extremely narrow. Meaning, they define who they are based on what two things? Where they are and what they're wearing. So the reason why they refuse to change their clothes and leave the room is they don't know who they are unless they are wearing those things in that room. And that's why they won't change it, because it terrifies them. So, as a nurse, would you make a functional psychotic who is refusing to leave their room and change their clothes, would you make them do it? Why? If you made them do it, they would cease to know who they were. You would have a panic escalation. Somebody would get hurt. So you do not do that. So what do you tell them when they refuse to leave their room and change their clothes? What do you tell a functional psychotic? I see you are uncomfortable or upset. You do not have to change your clothes or leave the room until you feel comfortable or until you're ready. And it's a perfect world so they can stay there for 30 years if that's the case. Don't say, well, they can't stay. I mean, that won't work because what if it's 3 weeks and they still don't feel comfortable? They won't be able to stay in the hospital that long. Hey, it's a perfect world. Yes, they can stay that long. However, what if they say this? Mrs. Jones has been depressed since her last child went to college 3 months ago. She has no energy to do the housework. She has lost her job because she didn't have the energy to get up and go to work. She says, I hate the way I feel. I am going to kill myself if things don't get better because this depression is ruining my life. Please help me. She is refusing to leave her room or eat her breakfast or do her daily hygiene care. What do you do?
Acknowledge how she feels, and then reinforce the reality that she needs to bathe.
Okay, but see, now you're taking the 4-step process for a psychotic. And this lady is a what?
Isn't she major?
She's a non-psychotic. She's a non-psychotic. She just said depression. She had insight, right?
So it won't you don't have to read into it if it's major or not?
If they don't say major, it isn't major.
Okay.
They have to specify major.
Okay.
So what do you use? Good therapeutic communication skills. But what do you say? I see you are depressed and feeling down, but what? What if a surgical patient is refusing to get out of bed after surgery? What do you do? Do you say it's okay? They can stay in bed all day?
Maybe you'll feel
What do you
better
tell
after
them? Do you
get
get
up.
them up and out?
Yeah, I say, maybe you'll feel better after you get up.
Yeah, but that's a guarantee. Maybe you'll feel better because they could walk and feel worse, and then now they don't trust you. You know what I mean? So what you would say is something like, it's time for you to shower, come with me, we will do. You're very directive because she doesn't have the energy to do it.
Tell them.
What's that? Tell them. Yeah, just like you would a post-op who won't get out of bed. Okay, now put your foot over the bed. Okay, now we're going to raise you up. Now put your feet on the floor. Now, okay, now stand up. You know, you're very directive because they're not what? Psychotic. So what's my point? What is similar about those two situations I gave you? And what's different? The one was psychotic, had the narrowed self-concept, was refusing to leave his room and change his clothes. The other one was non-psychotic depressed who was refusing to leave the room and change their clothes. One, I told you what? Do not push them. Do not make them. With the depressed, what do? You force them. You make them. If they don't make choices, you make choices for them. You understand? The only time you're allowed to make choices for patients is with depressed, psychomotorly retarded patients. You see? So, do you see the difference in the answers? Because your patient changed? Okay. Ideas of reference, that's when you think everybody's talking about you. For example, if two people were out there in the hall and they were talking, if I had ideas of reference, I'd think, what are they saying about me? Now, psychotics have really take this to the limit. I had one psychotic patient at Twin Valley where I took care of her. And every evening when Katie Couric came on the news, she'd take her shoe off and throw it at the TV and call Katie all kinds of choice names and say, why are you lying about me? I was never in New Mexico. I could not have done that. What did she have? Ideas of reference, because she thought Katie Couric was telling stories about her when it had absolutely nothing to do with her. That's ideas of reference. Do you remember that I said about the people that pointed at the table and said those people are plotting to kill me? That's paranoia plus ideas of reference. And we dealt with it 3 different ways depending on who the patient was, correct? Okay. Take a break, come back at 10 till, and we'll do diabetes. Yo.
Pretty West teaching people how to write reflection statements.
No, I never was. I've never been to. Of all the diseases you should know diabetes. I'm not one to tell you to go learn all these laundry list of diseases, but you do need to know your diabetes. So let's talk about it. Definition: diabetes is an error of glucose metabolism. You don't metabolize your glucose well. That's what diabetes is. You cannot metabolize glucose for whatever reason. Sometimes it's a lack of insulin. Sometimes the cells become resisting to insulin. For whatever reason, you cannot metabolize glucose. Now, the problem with glucose is it's your primary fuel source. So diabetics get into trouble because they can't metabolize or use the primary fuel source. And without that, cells die. And that's why it's very bad. Now, don't confuse it with diabetes insipidus, because diabetes insipidus is a totally different disease. Diabetes insipidus is not a type of diabetes mellitus. It's a totally different disease. Diabetes, in the parenthesis, I want you to put diabetes insipidus is polyuria, polydipsia, leading to dehydration. Due to low ADH. Due to low ADH. So when you get a question about diabetes insipidus, and they want to know what you see, what do you see? Polyuria, polydipsia, and dehydration, which looks a lot like diabetes mellitus, doesn't it? Because it has polyuria, polydipsia, and dehydration. So they look alike even though they're not the same thing. That's why they share the same first name, diabetes. So if you're sitting there and you can't remember what diabetes insipidus is, what's the best way to remember?
Dehydrated?
It's like diabetes mellitus, only just with the fluids. It's just the fluid part of diabetes mellitus. You don't get the glucose part. You just get the fluid part. And it's due to a low ADH. So what they'll ask you about diabetes insipidus is, a lot of times with diabetes insipidus, what they would ask you is, do you have a low urine output or a high urine output? And what you should say is, oh, okay, wait, diabetes insipidus, it's not diabetes, but it's like diabetes mellitus, and diabetes mellitus has a high urine output, so diabetes insipidus has a high urine output. Do you see how I want you to remember it? Now, what is the opposite of diabetes insipidus? What's the opposite syndrome of diabetes insipidus called? SIADH. So here's what I do. I don't memorize SIADH. And I don't memorize diabetes insipidus. Why? But I get the questions right. How can you get the questions right on SIADH and diabetes insipidus and not memorize them? Everybody knows that diabetes mellitus has what? Polyuria and polydipsia, right? You should know that. So therefore, diabetes insipidus has what? Polyuria and polydipsia. So SIADH is the opposite. So instead of polyuria, they have low urine output, oliguria, and they are not thirsty because they're retaining water. Do you see that? So if they said to you, who gains weight? Diabetes insipidus, diabetes, who gains weight suddenly? Diabetes insipidus, diabetes mellitus, SIADH. SIADH. Why? Because diabetes insipidus and diabetes mellitus lose water. Right? And when you lose water, you lose weight. SIADH is the opposite. So who would have a urine output of 200 milliliters per hour for 3 hours straight and a normal blood glucose? Who would have diabetes insipidus? Who would have an output of 200 milliliters an hour for 3 hours in a row with a glucose of 280? Diabetes mellitus. Everybody says mellitus. I just am from the East Coast, so I say mellitus. Who has 10 cc's of urine out in 3 hours and a normal blood glucose? SIADH. Do you see how I'm saying? I want you to memorize that because boards does test DI and SIADH regarding urine output. So the two diabetes look alike urine output wise. The SIADH looks opposite the two diabetes urine output wise. What's the relationship between amount of urine and specific gravity of urine? What's the relationship?
Opposite.
It's inverse or opposite, meaning the less the urine out, the higher the specific gravity, the more urine out, the... So what specific gravities would SIADH have? SIADH is opposite the diabetes. The diabetes, do they have more urine or less urine? Diabetes. They have more. SIADH would have less. So if the urine volume is going down, the specific gravity goes up. So it would have a high specific gravity. Whereas diabetes insipidus, well, that would have what kind of a urine output? High, because the two diabetes have high urine output. So if the urine output is high, the specific gravity is low. So do you see how you're going to do this? And if you know the specific gravities and the urine volumes with the SIADH and the DI, you're ready to go with those two diseases. That's all they're going to test. So who would have the nursing diagnosis, fluid volume, of SIADH, DI, and DM? Which would have fluid volume deficit? Now think it through. Fluid volume deficit would be, what would you be doing with your output if you ended up with low fluid in your body, high output, and those would be what? DM and DI. Who would have fluid volume excess? SIADH. Do you see how I want you to think it through? Okay. I always find if you link things with other things you know, it's a lot easier to remember them than just remember them separately. Okay, let's dive now let's quit talking about the pituitary. Let's talk about diabetes mellitus directly. The types, type 1 versus type 2. You have to know these. They will expect you to know the differences between type 1 and type 2. Type 1 has 3 names. Insulin dependent, that's the I. insulin dependent. J is juvenile onset. And K is ketosis prone. Ketosis prone. Ketosis prone. Now, one of those three will not be used after April 1. Which name will not be used after April 1? Juvenile onset. Okay, type 2s. The names are non all of those. So instead of insulin dependent, it is non-insulin dependent. Instead of ketosis prone, it is non-ketosis prone. And instead of juvenile, it is adult. Which of those three will not be used after April 1? Adult onset. So you'll actually have to memorize less after April 1. C, the signs and symptoms. You must know the 3 P's. Polyuria, polydipsia, and polyphagia. P-H-A-G-I-A. P-H-A-G-I-A. Polyphagia. What does polyphagia mean? What's it mean? I can't hear it.
Thirsty.
Thirsty is polydipsia. What's polyphagia? Increased appetite. But technically, no. Polyphagia does not mean increased appetite, although we use it to mean that. What does polyphagia actually mean? Increased swallowing. Now, if you eat a lot, what are you doing? Increasing your swallowing. But I want you to understand that that's not, when they say polyphagia, they are not always talking about eating a lot. For example, would polyphagia be a sign of increased bleeding after a tonsillectomy? Yes. And they're not talking about eating a lot, they're talking about swallowing a lot. See, so you understand, polyphagia technically means what? Swallowing a lot. In the context of diabetes, it's talking about eating a lot. The polyphagia only means eating a lot in this single context. Everywhere else, polyphagia means frequent swallowing. Okay? Treatment. If you don't treat type 1s, they could die. D-I-E. D for diet, I for insulin, and E for exercise. You treat diabetic type 1s with diet, insulin, and exercise. Of the 3, which one is the most important treatment modality? Insulin. By far and away, insulin is the most important. Which one is the least important of the 3? Nope. Diet. We do not mess around with type 1's diets anymore. We pretty much let them eat generally what they want. They count their carbs, they do their AccuCheck, and they give themselves the insulin accordingly. We don't restrict their diets like we used to. Now, we do tell them to lay off a bunch of refined carbohydrates, like, pure sugars. But they can even eat those nowadays, as long as they count their carbs and give themselves injections of insulin, according to their AccuChecks. However, the type 2s are different. Type 2s, if you don't treat them, they end up DOA. That doesn't mean dead on arrival. What that means is D for diet, O for oral hypoglycemic, which is the pill, and A stands for activity. Okay, of those 3, which one for a type 2 is the most important treatment modality? Diet. So what is the least important for a type 1 is the most important for a type 2. It's a huge difference. In fact, most physicians would like type 2 diabetes to be controlled with diet alone. They would really, really like that. I don't know if anybody watches Biggest Loser ever, and they'll say, I had diabetes and I don't have diabetes anymore. No, you still have diabetes. You're just controlling it because you're losing weight. Is anybody watching the current season? I'm not really watching. I just watch it every so often. There's a girl there on there, and she's wearing an insulin pump. You see it's like taped here, but they don't show it a lot, but she's wearing an insulin pump. And she's still over 200 some pounds. It'll be interesting when she gets down. Do we not see that anymore? Because probably we won't. We'll probably won't see that pump there anymore. But she is a type 1, so it may not work. But it'll be interesting. A lot of people, diabetes can be controlled with just diet alone, particularly type 2s. Okay, turn the page and let's talk about diet, insulin, and exercise more in depth. When we talk about diet, who are we talking about primarily? Which type? Type 2s. We're talking about type 2s. Letter A, it is a calorie restriction. The primary dietary modification we make with type 2s in their diet is to restrict their calories. That's the primary thing we do. Hence, you get things like the 1,200 calorie ADA diet, the 1,800 calorie, the 1,600 calorie. So it tells you that calories are important because that's how it's named. So a calorie restriction is the most important part of a diabetic diet. Letter B, they need 6 small feedings a day. So if they have 1,800 calories, how do you split that 1,800 calories? Into 6 separate feedings. Because what does that do? Yeah, it keeps it level so you don't get these big peaks. Because if you chalk that all in 3 meals, you're going to have these 3 big peaks. But if you do it in 6, it's going to be more level. And therefore, the blood glucose is going to stay more normoglycemic. Which one would be best? What if you got a question like this? You have a type 2 diabetic. What is the best dietary action to take? A, restrict their calories to an appropriate level. B, divide their food into 6 feedings a day. Okay, now, don't jump to conclusions because you have to understand this is a best question, right? And in a best question, how many do you get to do? 1. And if you say you're going to do 1, you're not going to do the other. In fact, you're going to do the opposite of the other. So if you pick A, all right, they're going to follow their calorie restriction, and it's 1,600 calories, all right? If you say, I am going to give them 1,600 calories a day, what does that mean you're not going to do? They're going to get it, what? In 3, just going to get 3 meals a day, and they're going to get 1,600 calories in 3 meals because we're not going to split it in 6. That's what you're saying if you pick calorie restriction as your best answer. Okay, let's see what you're saying if you pick 6, split it into 6 meals, 6 feedings. Okay, if you pick that, you're saying what? I'm going to split it into 6 feedings, but what? But they can eat as many calories as they want. So what would be better for a diabetic? To get 6 feedings a day, eating as many calories as they want, or to eat 3 meals a day following their calorie restriction? What would be better?
Restrict calories.
So what is the best answer? Calorie restriction. Do you see what I'm saying? And you have to be, because usually when you shout out an answer or you jump to an answer without the thinking, you tend to go to the wrong one. So think it through. Do you see what I'm saying? Are you understanding this process that I'm teaching you about how to deal with best questions? How do you deal with a best question? Narrow it down to how many? 2. If you can narrow it down to 1, what should you do? Pick it. Okay? But everybody tells me they can only narrow it down to 2, and then they don't know what to do. Well, if you narrow it down to 2, then what do you say?
What's the best of it?
I will do this one, but not do that one. And then flip it around, I'll do that one without doing this one. And one of those you'll like better. So pick the answer that's you're going to do in the one you like better. Question?
Would that still be the same if you're talking to a patient who's like 400 pounds and used to, like, let's say their baseline is 4,000 calories a day,
Okay?
but they have been real good at splitting those up into 6 meals?
Okay.
Would that still be accurate to say they need to slash those like instantly into 1,800 calories?
Okay, write the question.
You have
Are you talking about a question or are you talking about what do you do in real life?
I'm saying, yeah, for like a board's question, if you have,
Okay.
you know, like in
Write the question and then I'll give you the answer. But I need to know how you're going to phrase the question here.
what would be more preferable for a 400-pound patient
400 pound
whose baseline is 4,000 calories
a day.
to help control their type 2 diabetes?
Okay.
What is the best answer?
Okay, what's the best answer? Now, if the answers are reduce them to 1,200 calories versus teach them to separate the calories into 6 meals. And they're talking about starting. I might seriously question the 1,200 calorie because it's such a big, huge drop initially. But the best would be to drop to 1,200 calories. The best answer still is 1,200 calories. But I probably wouldn't do it first. Remember yesterday I said there's a big difference between a first and a best. So if they said to me, what would you do first? I'm not dropping him to 1,200 calories first. I'm going to teach him how to separate it. Then I'm going to start whittling down each time to get him there. Does that make sense?
Yeah.
So I think in your case, the 6 meals would be the first thing you might do in that scenario. Okay. But see, the only time that works is when you wrote that scenario specifically that way, which boards doesn't get that picky. They go more general because they want to know, if you miss it, did you not know what to do generally? Then they can say you shouldn't pass. Do you see what I'm saying? Because if you didn't know what to do in some specific unusual occurrence, if you miss it, they can't really fault you because nobody else knew it. Does that make sense? Okay. The problem is in school, you guys are given all these bizarre questions that are tricky, and they add this in, and they say, aha, but you forgot about that. So you miss it, and you get socialized into thinking that's the way. But on boards, they don't do that. I mean, boards is, but if you have to trust that boards is fair. And it really is. They're well-tested questions. Okay, does that answer the question?
Yeah.
Okay.
Thank you.
Let's see. Insulin. Insulin acts to do what to the blood glucose? What does insulin do to the glucose level in your
Lowers.
blood? Lower. It lowers the blood. That's good to hear. I went to a school one time and asked that question, and everybody said, raise. And I thought, oh boy, I have my work cut out for me here. So insulin acts to lower your blood glucose. Now there are 4 types of insulin you need to know. Now there are many, many types of insulin, but there are 4 that you really need to know for boards. You don't need to know Exubera, Byetta, Apidra. You do need to know R, N, Lispro, Humalog, and Lantus Glargine. So let's talk about these 4. Regular insulins, the ones with the big bold R on the bottle. It has actually lots of different names. It could be Humulin R, Ileton R, Novolin R. The name is irrelevant. What is important is that big bold letter R. That means it is regular. Its onset is in 1 hour. Its peak is in 2 hours. Its duration is 3 hours. It is clear. It's clear in the bottle. It's clear. So it's a solution. So it can be IV dripped. This is the insulin you use when you use IV drip insulin. Now, Hesse will call this an intermediate acting insulin. The product insert that comes with the bottle from the manufacturer that the FDA approves says it is a rapid, short-acting insulin. So I don't know why Hesse insists on changing the FDA's classification. But if you learned that it was intermediate, it is still considered by the FDA and the product insert as a short, rapid-acting insulin. Why do you think a lot of people are starting to talk about regular not as a short, rapid, but as an intermediate?
Because they use Lispro.
Exactly. Because 5 years ago, 10 years ago, we didn't have Lispro. And the fastest one was regular. Now we have Lispro that works in 1/4 the time that regular does. And it's kind of silly to talk about Lispro as being the same time phase as R, isn't it? But I really believe that if boards ask you, is R short, rapid, or intermediate, you should go with what the FDA and the product insert says, not what Hesse says. Do you see what I'm saying? Or Hesse's books, anything from Elsevier will say it's intermediate. Okay? All right. NPH insulin, N, is truly an intermediate acting insulin. It's a true intermediate acting insulin. Its onset is in 6 hours. Its peak is 8 to 10 hours. And its duration is 12 hours. It is cloudy. It is a suspension, as all cloudy things are. They are not solutions. Cloudy things are suspensions. Clear are solutions. Cloudy are suspensions. And the bad thing about a suspension is a suspension precipitates, meaning the particles fall to the bottom over time. So you cannot give this drug IV drip, or you will overdose them and their brain will die. But there's a general rule, never put anything cloudy in an IV bag, right? When I have students clinically, I'll teach them something that can help them a little bit. When they pull out an R, a bottle of R from the shelf or the refrigerator, I'll say, what does that R mean? And they will say, regular. And I will tell them, no, it doesn't. Whereupon they start to panic. And I say, wait a minute, I'm just trying to teach you something here, so don't panic. Yes, it does mean regular, but I'm trying to tell you that R really means two other things. That R stands for rapid and run. Rapid meaning it's what? Fast acting, and run means run at IV. They will pull out the N bottle, and what's the first question I ask them? What does the N stand for? And they'll say NPH, and I'll say no. And they'll start to panic, and I'll say, wait a minute, I'm just trying to teach you something here. That N actually stands for two other things. Do you know what that N stands for? Not so fast, which means it's what? Intermediate, and not in the bag, which means you never put it where? IV. Because I want my students, the minute they pull that N off the shelf, what do they say? It says a big N on it. And they say what? Not so fast and not in the bag. So they will never what? Draw it up and stick it in an IV bag because they know N is not in the bag insulin. Actually, my students will forget that it's NPH. They'll call it not in the bag and not so fast insulin. And R, they'll call it rapid and run insulin. And I think that's kind of functional. It kind of works. All right, now, let's talk about the onsets, the peaks, and durations of these famous insulins. Look at the pattern. What do you see as you read across the page? 1, 2, 4, 6, 8, 10, 12. 1, 2, 4, 6, 8, 10, 12. What are you counting on?
You said 3, let's get 4.
Did I mess up something? What did I say? Okay, the regular onset is, 1. Peak is 2. Duration is 4. I'm sorry, did I say 3? I was thinking Lispro. I'm sorry. So it's 1, 2, 4, 6, 8, 10, 12. Do you hear the even numbers? So what's 1, 2, 4? Regular. What's 6, 8, 10, 12? N. So just remember 1, 2, 4, 6, 8, 10, 12. 1, 2, 4, 6, 8, 10, 12. Which of those will they test the most commonly? Of those, no, they test N and regular equally. The peaks. They test the peaks. So what do you really have to remember? 2 and 8 to 10. The way they'll test it. In fact, how do they test it? You tell me how they test it. What does the question read like?
Give you a time, blood sugar, and
They gave you gave 30 units of N at 7 in the morning. Then what do they ask? When would you check for hypoglycemia, which means low sugar? Well, the low sugar is going to be when the med's at its peak. So that's the way they ask for the peak without ever asking about the peak. They ask about hypoglycemia, which is the peak. So if you gave N at 7, when would you check for hypoglycemia, which is the peak? N. You gave N at 3 p.m. to 5 p.m. Somewhere between 3 and 5 p.m. Or late afternoon, they would say. See how that works? Take the peak, add it to the time they gave it. That's when you check for the hypoglycemia or the peak. Humalog, Lispro, the world's fastest acting insulin. Its onset is in 15 minutes. It peaks in 30 minutes, and its duration is 3 hours. 1533. So when do you give this insulin? As they begin to eat. So you give it with meals, not AC. What does AC mean? PC means after meals, post, PC. A means ante or before. So AC means before the meal. Do you give Lispro AC before the meal? No. You give it with the meal. So be real careful with your words there. The word before is wrong. The word with is correct. I tell my students, if you're not interrupting their meal to give them their Lispro, you're doing it wrong. You don't give it when the trays arrive on the unit because it may take another 15 minutes till they get passed. By then, the Lispro is already working. And then you can't arouse them to eat because it's peaking. All right. Lantus. Lantus is a long-acting insulin. It is called Glargine, Glargine. And nowadays, they're most likely to call it Glargine rather than Lantus. Glargine. It's a long-acting insulin. It is so slowly absorbed, it has no essential peak. It is so slowly absorbed, it has no essential peak. What that means is this one has low risk for hypoglycemia. Little to no risk of hypoglycemia. So this drug is the only insulin you can safely give at bedtime, because they will not go hypoglycemic during the night with this one. The others you cannot give at bedtime. The only time you can give the others at bedtime, well, you never give N at bedtime. But the only time you can give R or Lispro at bedtime is if what? Your Accucheck said they were sky high, then you can give it. But you wouldn't routinely give Lispro or regular at bedtime. You can give Glargine routinely at bedtime regardless of the glucose. Duration is 12 to 24 hours. So those are the main insulins and what they're going to test. Letter B, check the expiration dates on your insulin. Please, that's important. what action by the nurse invalidates the manufacturer's expiration date? What action by the nurse invalidates the manufacturer's expiration date on the bottle? What's that? Opening it. Opening it does. The minute you open a vial of insulin, what is now no longer valid? So the manufacturer's expiration date is only good as long as it's still closed and sealed and unopened. Once you open it, now the manufacturer's date is irrelevant. What becomes the new expiration date is 30 days after that. And make sure you write on the bottle that date, and make sure you write EXP or opened. Why do you need to write opened and then the date, or EXP and then the date? Why can you not just write the date on it? Well, if I come along and I see a date, I don't know if that's when you opened it, and I don't know if that's when it expires. So when in doubt, I will throw it out, and I'll throw that insulin away. So you put EXP and a date, or opened and a date, okay? Make sure you're clear. Refrigeration is optional, meaning you don't have to refrigerate insulin in the institution. But you do have to teach patients to refrigerate their insulin at home. Now, in the hospital, the insulin that probably should be refrigerated are the unopened vials. However, once a nurse opens a vial, two things happen. Number one, the manufacturer's expiration date is no good anymore, and you got to write a new expiration date on it. And number two, it now does not have to be refrigerated in the hospital. So if they said to you, what's the most important thing, the best thing to do when you are dealing with insulin in the hospital? And you're between, check the expiration date before you give it and refrigerate it when not using it. What's the best answer? Well, you'd have to figure that out. If you pick check the expiration date before you give it, you're not going to do the other one, which was what? So you're going to check the expiration dates but leave it out of the refrigerator. Or you will what? Refrigerate it and not check any expiration dates and maybe give expired insulin. So it would be better to give cold expired insulin or warm non-expired insulin. Warm non-expired. Do you see what I'm saying? So the answer, best answer is expiration date. Okay, exercise potentiates insulin, which means does the same thing as. Potentiates means does the same thing as. I want you guys to think of insulin, I want you to think of exercise as another shot of insulin. Whenever the question says, and he exercised, what do I want you to replace those words with? And he got another shot of insulin. She's going to play soccer this afternoon. Replace that with what? And she's going to get another shot of insulin this afternoon. He has gym class this morning. He's going to get an extra shot of insulin this morning. Do you see what I'm saying? So if that's the case, if you have more exercise, what's that mean? More shots of insulin, you actually need less insulin. But if you have less exercise, you need more insulin because exercise is like an extra shot of insulin. So if a diabetic is going to play soccer in the afternoon, what should the school nurse do? He's going to get an extra shot of insulin, so he better what? What should he take to the game? Rapidly metabolizable carbohydrates, right? As a snack before the meal, before the game, and during the game. Okay, sick days. Diabetics get sick for other reasons besides their diabetes, like they get the flu, they get diarrhea, they get otitis media. What do they do when they're sick? Well, when a diabetic is sick, their glucose is going to go up. It'll never go down. It always goes up. So they have to take their insulin, even though they're not eating. Because a diabetic, let's say a diabetic gets the GI flu and he is nauseated and he's throwing up and he's not eating. What's he going to say? Well, I'm not eating, so I shouldn't take my... Do you hear why but that's wrong. Your glucose is going to go up even if you're NPO, when you're under the stress of illness. So they take their insulin, even though they're not eating. Number 2, take sips of water because they're going to get dehydrated. Diabetics get dehydrated. It probably would be worth your while to remember that a sick diabetic has 2 problems: hyperglycemia and dehydration. Any sick diabetic is going to have those 2 problems. So just count on it. Hyperglycemia and dehydration. Always. Every sick diabetic will have those problems. And then stay as active as possible. Why? It helps lower the glucose. And they're a sick diabetic, even if they're not eating, their sugar's going to go which direction? Up. All right. Now before lunch, we'll see what we're going to go to lunch at noon. Before lunch, I want to cover the complications of diabetes, and we'll see where we're at after that. There are 3 acute complications of diabetes and a boatload of chronics. Let's talk about the acute complications first. You should never go to boards not knowing this, because they test this all the time. You have to know your signs and symptoms and treatment of the 3 acute complications of diabetes mellitus. The first one is low blood glucose in a type 1 or a type 2. It's called insulin shock, insulin reaction, or hypoglycemic shock, or hypoglycemia. It has bunches of names. It means their sugar is low. Their glucose is low. Now, what in the world would ever cause a diabetic's glucose to go low? That's a good question. Because when a diabetic isn't sick, but has diabetes, what does their sugar run? High or low? High. And when they get sick, it runs even higher. So if you're well, it's high. And if you're sick, it's even higher. So how in the world could it ever go low? Great question. Well, here are the causes. Not enough food, too much insulin or medication, and too much exercise. Wouldn't those all make the sugar go down? However, one of them is the primary cause. Which one is the primary cause? Too much medication. In fact, I would say that it is impossible for a diabetic to have a low glucose without being over-medicated. So over-medication is the number 1, almost sole cause of hypoglycemia in diabetics. The danger here is brain damage. And the bad thing about brain damage, it's permanent. So this is no small thing. You can destroy people's lives as a nurse by over-medicating them with insulin. You can take an alert-oriented person like me and cause me to be in a persistent vegetative state in a nursing home for the rest of my life because you made one mistake with insulin. Okay? What were the signs and symptoms? The signs and symptoms you must know, because boards will want to see if you can pick up hypoglycemia just by looking at the patient. Now, the easiest way I know to memorize the signs and symptoms of hypoglycemia are drunk in shock. Drunk in shock. Now, what am I talking about on this one? Here's what I'm saying. Most of you guys in here know what drunk people look like. Okay? So what does a drunk person look like? Describe it for me.
Staggering.
Staggering gait. Slurred speech. Judgment. Poor judgment. Impaired judgment. Reaction time. Delayed. Emotions. Drunk person's emotions. Talk to me. Okay, but they won't say all over the place. They'll use a fancy word called labile. Labile, which means all over the place. Laugh, cry, laugh, cry. Could they be a little obnoxious and belligerent? A little bit loud? Decreased social inhibition? Those are all signs of hypoglycemia. So anything that would characterize a drunk person will also characterize a hypoglycemic person, because both people are having cerebral cortical compromise. Now, the other part of the picture is shock. They also look like they are in shock, which is the vasomotor part of the syndrome. So what does a person in shock look like? Low blood pressure, tachycardia, tachypnea. What else? Skin, cold, pale, clammy. Could it be mottled in the extremities? Patchy, yeah. So, what I want you to do is, I'm assuming that everybody in here knows what drunk people look like. And I'm assuming you know what shock looks like. So I'm saying to get hypoglycemia, all you do is add those two. Drunk plus shock. So I don't want you to memorize any new list. Just derive the new one from two old ones you already knew. So drunk is drunk, shock is shock. Add them together, you get hypoglycemia. So when you get a select all that apply for hypoglycemia, what do?
Look for the drunk and the
Go through and
shock.
select everything that applies to whom? A drunk, and then select everything that applies to a person in shock. And I'm not talking about anaphylactic or neurogenic or septic shock. I'm talking about shock, generic, basic, oh my goodness, I'm bleeding to death shock. Right? Well, what do you do for it? Number one, administer rapidly metabolizable carbohydrate, i.e. sugars. If boards says, if you're looking for the word sugar and it's not there, they probably are saying rapidly metabolizable carbohydrate, because that is synonymous with the word sugar. Now, what would be some examples of a rapidly metabolizable carbohydrate that you could give in a hypoglycemic situation? Any juice. There's nothing magical about orange. It could be apple, grape, pineapple, guava, pomegranate, grape. What else besides fruit juices? Now what? Low calorie, sugar-free pop? No, regular pop. Which a lot of times they go, oh wow, cool. I get to have pop. What else? Chewed up candy. Let them chew it up. What else? What? Well, no, crackers don't have enough sugar. Milk is great because it has lactose, so it's got the sugar. Honey, icing, jam, jelly, those are great, rapidly metabolizable carbohydrates. Okay, however, boards really want you not to give just a sugar. They want you to give an ideal combination of foods, which is the next point. What is the ideal combination of foods? You want a sugar plus a starch or protein. That's where the crackers come from. The crackers are the starch, the orange juice is the sugar. Orange juice and crackers, good job. Because you got the sugar and you got the starch. Or you could say apple juice and a slice of turkey. Because what would that be? Sugar plus protein. Which is why the milk is so fantastic. Because when you drink milk, what are you getting? Sugar and protein, which is perfect. But you use skim milk because you don't want them to burn fats for the ketones, right? So it's 1/2 cup skim milk. Fantastic answer for hypoglycemia. 1/2 cup skim milk. What's a bad answer? What's a bad combination of foods to give them? What would be a bad combination of foods to give them?
Two carbs,
Such as,
crackers.
no, not carbs. No, carbs was too broad.
Like candy with cola.
Yes, giving them a bottle of pop and a bunch of candy to chew on. You know, one sugar is good, two sugars are bad. So give them one sugar and one starch, one sugar and one protein. So what do you think about 5 packs of sugar emptied into a glass of orange juice? Not the way to go. It's not the way to go. Okay. What if they're unconscious? What do you give them? Glycogen, or glucagon actually, glucagon, which gives you mobilizes the glycogen. Glucagon IM, a shot, an intramuscular injection of glucagon. What else can you give them? By another route.
So dextrose.
Dextrose per IV. But D5 is not going to do it. It's going to be D10, D50. Because D5, a whole liter at D5 only gives you 300 calories.
So D10?
Yeah, you need some D10, D50. You need some real powerful dextrose. Not just D5 won't do it. So, what will determine which one you give? The D50 IV or the glucagon IM? Because they're both appropriate.
Accessibility and not able to be available or the
So what will determine that?
Rather than shop.
The setting. The setting will. If you are talking to the mom and dad over the phone, and they're asking what they do with their unconscious hypoglycemic diabetic kid, what do you tell them to give? The IM glucagon that they should have in the refrigerator. They should all have one in there. What do you not tell them to do? Start an IV of D50. However, if they tell you it's in the emergency department and you got a severely unconscious hypoglycemic client with a glucose of 7, what do you give them? IV of dextrose. But good luck starting the IV. Because they look like a what? Drunk in shock. And what happens to peripheral vessels in shock? So good luck. You know. That's why I love saline locks and heparin locks. Intermittent venous access devices. Because if I need a lifeline in an emergency, it's going to be there. Because the hardest time to start an IV is a lifeline is in an emergency because they clamp down peripherally and you can't get a vessel, can't get a cannulation because it's vasoconstricted. That's one where you just aim for where the veins are supposed to be, you know, because you can't see anything. Alrighty. Number 2. High blood glucose in a type 1. It's called DKA, diabetic ketoacidosis, or diabetic coma. Have you heard of DKA? Mm-hmm. I hope you have. Who gets it? Only type 1s. What should have told you it was only type 1s? How should you have known it was only a type 1? That only type 1s get diabetic ketoacidosis? Because another name for type 1 is what? Ketosis prone. And type 2 is non-ketotic. So how can a non-ketotic have diabetic ketoacidosis? They can't. So only a ketosis prone type 1 can have DKA. Well, what would cause their glucose to go high? Well, too much food, not enough medication, not enough exercise will make the glucose go way high. However, none of those are the number one cause of DKA. The number one cause of DKA is below. The number one cause of DKA is acute viral upper respiratory infections within the last 2 weeks. So what causes DKA? Number one cause of DKA.
Viral
A type 1 gets what?
A viral?
The virus of the month club at school, right? and they get the upper respiratory viral pharyngitis that every kid in school has, right? And they recover from that within 3 to 5 days like everybody is. But after they recover initially, what starts happening? They start going downhill and getting more and more lethargic, because this is called diabetic ketoacidotic coma, DKA. So they start going downhill. So that when they come in the ER and you check their blood glucose and it's 850, and they have the signs of DKA, what do you ask mom and dad? That was when the last time they ate.
Have they had a viral infection in the last 2 weeks?
Yes. Have they had a viral infection, upper respiratory, in the last 2 weeks? What will they almost always say? Yes. And what caused the glucose to go high was the stress of that illness that was not shut off. And they started to burn fats for fuel, and they got into a negative situation. Well, what are the signs and symptoms of DKA? Turn the page. What are the signs and symptoms of DKA? I like it because they are DKA. You can get the signs and symptoms from the initials of the disease. So, D stands for dehydration. They look dehydrated. You should have known that, because what did I tell you sick diabetics always get? And a high sugar. And these people have a high sugar and they are dehydrated. Classic. The K stands for 3 things that start with the letter K. They have ketones. Now, just for fun, DKA. Tell me if this is a true statement. DKA, they will have ketones in their blood. They will have ketones in their blood. True. Okay. DKA. Everybody with ketones in their urine has DKA. No. So you can have ketones in your urine and not have DKA. But if you have ketones in your blood, you have DKA. So it's the ketones in the blood that confirms the diagnosis. The ketones in the urine, that doesn't typically mean that you have DKA. Okay, the second K is Kussmaul. They Kussmaul. What's that mean? Deep and rapid. They hyperventilate. Deep and rapid Kussmaul. And the third K is K. They have a high K, which means what? Potassium. Potassium. The A stands for 3 things that start with an A. They are acidotic. What kind of acidosis? Metabolic, and that fits with Mac Kussmaul, doesn't it? A, they have acetone breath. Acetone breath, which means they have a fruit odor to the breath. And it's not always a nice mango essence either. It can be a rather funky, fruity smell. And A, they have anorexia due to nausea. Anorexia, what's that mean?
They don't want to eat.
They don't want to eat. Why? Because they're nauseated. So if you said to me, Mark, what are the signs and symptoms of DKA? I'd say, well, let me think here now. D, dehydration. So they're what? Dry, mucous membranes, weak, thready, pulse, dry skin, poor elasticity, headache. What would the skin be if you're dehydrated?
Panting.
Poor elasticity. What else? Dry. What temperature? No. Water in your body performs the same function as water in your car. If you dehydrate your car, meaning spring a leak in your radiator, and you leak water out of your car and you dehydrate your car, what will happen to your engine? It'll overheat. So water is a coolant. So if you dehydrate, you overheat. Your skin will be what? Hot and flushed. Hot, flushed, dry. That's dehydration. See, I'm assuming you knew the dehydration signs. Maybe that was an assumption I shouldn't make. So DKA, first you check off all the dehydration signs, right? Then what do you check off? Ketones, Ku small, and K. Then you check off acidosis, acetone breath, and anorexia due to nausea, DKA. 1D, 3 Ks, 3 As. And those are the signs and symptoms of DKA. Well, what do you do for it? Well, they're dehydrated and their sugar's high. So what do you do for the dehydration? IV fluids, low or fast rate? Fast rate. This one would be around 200 an hour. Some of the fastest rates you'll use are these ones. Burn is, of course, the fastest rates that you run in the first phase. But these ones are pretty high. And what do you put in the bag? The IV bag. To lower the sugar. Regular insulin, because you can run that. So you're going to get an IV with regular insulin run at about 200 an hour. That's pretty standard. And the main solution doesn't matter. It doesn't matter whether it's normal saline 0.45, D5 0.45, D5W. You're going, but their sugar's high. Why are they getting D5? What did I say about D5? 300 calories. So even if you run it at 200 an hour, they're only getting 60 calories an hour. That's nothing. You see what I'm saying? And anyhow, the D5 molecule is small, so it just goes right out. As soon as it gets in your bloodstream, it goes into the tissue. It doesn't even stay in your bloodstream to contribute to your glucose. If you guys have ever been taught to worry about the dextrose in the IV bag because of a diabetic, that's poor teaching, because that doesn't even stay in the veins. It goes into the tissue. The dextrose in the bag, if it's D5, will not create a hyperglycemia situation. Now D10 will, D50 will, but D5 will not. So don't worry about the dextrose in the bag. It's no big deal. We used to be all over that when I was in school. Oh, they're diabetic. Get the D5 out of there. It's not real good practice anymore. Okay, number 3, low blood glucose. I told you the type 1 is the same as type 2. Number 4, high blood glucose in a type 2 is called HHNK, HHNC, and some places call it HHS or HHNS. Which one do you guys use? HHNK? Did anybody use HHS? HHNS? HHNC? It's all the same thing. Who gets this? Which type? Why should you have known that a type 2 gets this? What in the name tells you it's a type 2? Non-ketotic. And whenever you see the prefix non, you know it's a type 2. Type 2s are the ones that have the nons. Type 1 never has anything that has non in it. Now, how many of you in here, if you got a bunch of questions on HHNK, hyperosmolar, hyperglycemic, non-ketotic coma, on your test, would kind of get a little nervous? Simply because of the length of the name. Well, this is actually one of the easiest questions you can get because it is very simple to understand. Letter B, this is dehydration. That's all it is. Here's my point. How many of you in here, if I told you, you have a choice of taking 2 tests. One test is 20 questions over the causes, signs and symptoms, and treatment of HHNK. And the other test is over the causes, signs and symptoms, and treatment of dehydration. Would you have a preference? Which one would you rather take? No, but before I said anything, a half an hour ago, what would you have chosen? Dehydration, not HHNK. But what's the reality? It's the exact same test. So here's my point. Wherever you see the phrase hyperosmolar, hyperglycemic, non-ketotic coma, you can pull that out and plug in what word? Dehydration. Answer that question, you will get it right 100% of the time. So what would the skin look like in HHNK? Don't answer that. What would the skin look like in dehydration? Low water. Hot, flushed, dry. What would be the number one nursing diagnosis that you would see with HHNK? We'll refuse to answer that. What would be the number one nursing diagnosis you would see with dehydration? Fluid volume deficit would be your number one nursing diagnosis. What would be your number one nursing intervention or medical intervention for a client with HHNK? Well, I refuse to answer that. What would be the number one nursing or medical intervention in a patient who is dehydrated? Giving fluids. Do you see? What would be some outcomes you would want to see in a client with HHNK? Increased output. What's that? What? Coming what direction? Up. What's that? Moist mucous membranes. All the things that you would like to see if somebody were dehydrated. What would the outcome of your treatment want to be? You'd want to see them. So I guess what I'm saying is don't make HHNK hard. Make it easy. It's nothing more than dehydration. It's actually DKA without the K or the A. Because if you take DKA and you take the K out and the A out, what do you have left? Dehydration. That's HHNK. Why do HHNKers not get the Ks and the As and only the D? Because they don't burn fats, they don't make ketones. If you don't make ketones, you don't get ketones. If you don't get ketones, you don't get acid. If you don't get acid, you don't Kussmaul. If you don't if you don't get acid, you don't have the K shift that raises it. If you don't have the ketones, you don't have the acetone breath. And if you don't have that, your lining of your gut doesn't swell and make you nauseated. So what did I just rule off the DKA list? All of the what? Ks and all of the As, and the only thing I had left was the D. That's why HHNK is just the D, whereas DKA is the D, the K, the As. Does that make sense? I want you to look at this. Okay. Therefore, which one is the use of insulin most essential in treating? HHNK or DKA? Which one is insulin the most essential in treating? Well, if I said HHNK and DKA, you would immediately change HHNK to what? Dehydration. And if I said, in what situation do you need to use insulin? DKA or dehydration? What would you say? DKA. So the answer is DKA. You don't have to use insulin with HHNK. All you have to do is rehydrate them because they are dehydrated. By the way, which one is more life-threatening? Which one has a higher mortality rate, more people die of? HHNK or DKA?
DKA?
No, actually, more die from HHNK. Which one, if a DKAer comes into the ER and an HHNK comes into the ER, who is higher priority? The DKAer. Which doesn't seem to make any sense. Because I just said, who has a higher mortality rate? HHNK, but who's a higher priority? DKA. Well, can someone explain that to me?
The HHNK, they come in later when they're...
They come in a lot later because they don't have the acidosis, the ketosis that makes people see symptoms. And so they get worse and worse and worse. So by the time they come, they're already bad. But a DKAer is acutely ill with all these symptoms that we can quickly treat with a simple rehydration with insulin. Do you see? Whereas the HHNKer will probably be treated with IVs, but probably is in such bad shape they're probably not going to make it anyhow. But you understand what I'm saying? Now, who would die first if we didn't treat them? HHNK or DKA? DKA. But we treat them so they actually have a lower mortality rate, even though it's more life-threatening. Does everybody get that? Okay. Long-term complications of diabetes are related to two problems. Oh, by the way, okay, B said this is dehydration. C says the signs and symptoms are like signs and symptoms of dehydration, and the treatment is rehydration. Did you get those blanks filled in? Good. Number 5, the long-term complications of diabetes are related to letter A, poor tissue perfusion, and B, peripheral neuropathy. Poor tissue perfusion and peripheral neuropathy. Now, what are some long-term complications? They are not DKA, HHNK, and hypoglycemia. Those are acute complications. I'm talking about renal failure, gangrene, stasis ulcers, blindness, impotence, heart disease, brain disease. So, if they ask you, diabetics have renal failure, what would this be due to? Well, it's one of two. Which two is it up? It's one of the two. Either what? Poor tissue perfusion or peripheral neuropathy. If it's renal failure, which one do you think it is? Poor tissue perfusion. If it's that they lost control of their bladder and they are now incontinent, what is that? Peripheral neuropathy. They can't feel it when they injure themselves. Peripheral neuropathy. They don't heal well once they injure themselves. Poor tissue perfusion. See, you're going to always blame it on either poor tissue perfusion or peripheral neuropathy, whichever one makes the most sense. It'll be pretty logical for you. Number 6, which lab test is the best indicator of long-term blood glucose control? The hemoglobin A1C. The HA1C. HA1C. The hemoglobin A1C. It's also called the glycosated hemoglobin. The glycosated hemoglobin. I've also heard it called the glycosylated hemoglobin. It's the same thing. Glycosylated hemoglobin, glycosated hemoglobin, hemoglobin A1C are all the same test. Now, what numbers do you want to see with the HA1C? You want it to be 6 and lower. 6 and lower.
6 what?
Just 6. On boards, they never test units. So all you need to know is numbers, which is great. What hemoglobin A1C means you're out of control. 8 and above is out of control. So in the 6s and lower means in control. 8 and higher means out of control. So where's the problem? With a 7. So the question is, when they come in with a hemoglobin A1C of 7, what's the conclusion? Yeah, they're on the border. So what do they need? Some workup. They need some evaluation. They need brought in the hospital, checking out what's going on. They might have some infection somewhere. So a hemoglobin A1C of 7 means we need to check on you. 6 means you're good to go. 8 means you're out of control. 7 means maybe. So just so you understand what the implications of those numbers. You'll see on TV, I just saw an advertisement the other day. It said that a certain thing lowered the A1C 0.9, which actually is really almost the whole point, which could take you from out of control almost to control. So it doesn't sound like much of a change, but for an A1C, a 0.9 change is huge. All right, let's get our, is stuff here?
It's here, down on the table.
Okay, let's get our blood sugars up. I feel bad because we're going to end up doing dumping syndrome right after lunch. That's not good. That's what happens.
When we did that one day when we brought in our meals that day, we were doing anorexia.
Yeah, the anorexia.